Hello, everyone. My name is Dr. Yonit Arthur. You are on the Steady Coach. And today we're going to be talking about an important topic that comes up a lot in the comments on my YouTube channel relating to why do I even need to work on stress and what do emotions have anything to do with my recovery from chronic dizziness symptoms? Many of you have clearly gotten the message that I want you to react to symptoms differently, to work constructively with anxiety, to work with fear in a different way. And so many of you are doing such a beautiful job with that. But then what I often will hear is, gosh, I'm doing that and I'm reacting better, but I'm still dealing with symptoms. What do you mean I need to work on my stress or work through my stress? So in this conversation, we're going to be talking about what we mean by stress, what emotions have to do with stress to begin with, and we're going to talk about a type of therapy that is used specifically for medically unexplained chronic dizziness, chronic pain, chronic fatigue, tinnitus, hyperacusis, etc., that is currently being researched. One of the researchers is actually here for this interview. We'll get into that in a moment. And I think you're going to walk away from this conversation not just understanding why you'd want to do this, but also with some practical ideas of what this looks like and how you may be able to implement this using the tools that are available for free on my channel and in the free course. My guest today is Dr. Brandon Yarns, MD, who is a board-certified geriatric psychiatrist. He is a staff physician at the VA of Greater Los Angeles Healthcare System, and he is an assistant professor at the University of California, Los Angeles, Department of Psychiatry and Biobehavioral Sciences. Among many other things, Dr. Yarns is a practicing clinician who works directly with patients. He is also a researcher who is researching, among other things, emotional awareness and expression therapy, EAET, which is a type of therapy that leverages our understanding of emotions and stress to help people with medically unexplained chronic dizziness, pain, and other symptoms get better. Now, it is important to state here that Dr. Yarns' participation in this podcast is separate from his work at the VA and UCLA, and his views are his own and do not represent the views of the VA, the U.S. government, or the University of California. That being said, I think you're going to walk away from this conversation with a much greater understanding of how to address your own stress and, again, how to use some of the tools to further your recovery. If you enjoy this video, please be sure to like it. Please share it with people you think will enjoy it. Subscribe to my channel. Leave some questions and comments below if you're on YouTube. If you're listening to this as a podcast, please be sure to head on over to YouTube to join the conversation. I love hearing from you. You can also subscribe or follow the podcast and leave a 5-star rating. Those things really help us reach more people. Please enjoy this conversation with Dr. Brandon Yarns. Well, hello, Brandon. Welcome. I was going to say welcome to the channel, but it's actually welcome back because we already recorded some of this interview and were thwarted by technical problems. So we're here again, and I so appreciate your time today. Thank you so much for being here.
It's my pleasure. Yeah, it's really an honor to be on the channel. So thank you so much for inviting me.
Yes. Well, I'm so glad to have you. We're going to be talking about a lot of really important things today. So welcome to all of you for tuning in. Most importantly, I think we're going to be talking about a method of working with chronic symptoms that was developed specifically for chronic symptoms, for helping people with medically unexplained chronic pain, chronic dizziness, vertigo, brain fog, whatever, all of those kinds of symptoms that we talk about here on my channel and elsewhere. And this is a method that you helped develop. So you are such a wonderful guest to talk about it. Before we get into that, I was hoping you could just give us a little bit of your background and how you got into your area of expertise, which is actually chronic pain.
Yes, thank you. So I'm actually a geriatric psychiatrist. It's a psychiatrist who works with older adults, and my specific population is older veterans, actually, in the U.S. military who served. And so when I was in my psychiatry training, I developed a very strong interest in psychotherapy, which is perhaps a little unusual these days for psychiatrists who mostly prescribe medications. But when I was in my training, I was very fortunate to gain this mentor in a type of psychotherapy called intensive short-term dynamic psychotherapy, or ISTDP. And the thing about ISTDP that's so cool is that part of learning it and practicing it is video recording all of your sessions with your patients, so you can review the video recordings and figure out how to help the patient more next time. It's part of the reflection process and helping the patient. But that means when there are presentations, like, you can see actual sessions that expert therapists have gotten their permission from patients to show. And it's just what it sounds like. It's intensive. Can be dramatic changes, very deep changes with patients in the course of one session. But the problem is there was not a lot of clinical trial support. So ISTDP was not an evidence-based treatment in the usual sense with clinical trials. So when I finished all my psychiatry training, wanted to develop research training to study ISTDP in clinical trials. And so I came to UCLA to do a research fellowship, and I was trying to figure out how we would study it. And I discovered also my mentor, Patricia Coughlin, introduced me to Mark Lumley and Howard Schubiner.
Names people will know.
Yeah.
Yes, on this channel. Yes.
They had developed this sort of manualized version of ISTDP called Emotional Awareness and Expression Therapy, EAET, that was for specifically chronic pain and other mind-body symptoms, as you mentioned. And Mark had gotten a large grant, an R01 grant, to study this in a clinical trial. And so they very generously shared their materials with me, which I thought was fantastic. They were really impressive. So I did make some adaptations. I don't know if I could say I helped develop it, but I definitely adapted it heavily for my older veteran population. I did a pilot study where I led group EAET, and then I got a larger grant to study EAET, which was published just a couple months ago. And I'm now working on my second grant studying EAET. So we're developing that clinical trial data right now.
Very cool. And we're going to talk about some data actually that you collected recently and was just published. But before we go there, just some important background information I think people are going to need. So you mentioned you're a psychiatrist. You mentioned you developed this interest in psychotherapy, and ISTDP, or intensive short-term dynamic psychotherapy, was something you saw make tremendous changes for people very quickly. It sounds like that method is often used for mental health conditions because that's generally what psychiatrists specialize in. So what's the reason for wanting to use a method like that for something like chronic physical symptoms?
Yes, I think that's an excellent question. And so one thing I think people don't really appreciate in my field and in the larger medical field is how the brain and the mind, which is really our way of understanding the brain, using plain language, is involved in every single process in the body. There are so many connections throughout between the brain and the whole nervous system, all the way from the top of your head to your toes. And their brain controls the flow of chemicals and hormones throughout the body, like stress hormones. So it influences or directly controls every single organ system in the body. And very interestingly, Freud, who was one of the first, the first psychiatrist, person regarded as a psychiatrist, he came from neuroanatomy. He studied
Oh,
the brain, and it has developed an interest in physical symptoms that could not be understood through neuroanatomy and neurology at the time. And so this tradition of using, looking at the brain, the mind's role in physical symptoms, it really goes right back to the beginning. And so I thought it was just very natural. It's a very fascinating field, and I think it's so important because it's misunderstood, not by people on who watch your channel, but unfortunately by a lot of doctors out there, that there perpetuates this mind-body split.
right.
They just focus on the organ or the tissue where the symptom is occurring and not the big picture. And so that's what we're trying to do, is integrate all of that to really help people in a deep, meaningful way.
Okay. And I want to come back to how ISTDP and EAET work, or what your theory is on why they work. But before we do that, do you think what you just mentioned explains why, generally speaking, mainstream medicine and mainstream medical physicians will often take this management approach to chronic physical symptoms, that they just don't see that it's possible for that to change?
Yes, I do. And one thing that I wanted to say in the first take that we did is how, yeah, I don't really know a fraction of what you know about dizziness, but in chronic pain and chronic back pain specifically, patients get all sorts of different diagnoses, that it's a slip disc, and then another doctor says, it's spinal stenosis, it's a SI joint dysfunction, and you need this injection, this physical therapy, this medication, this surgery, perhaps. And so they get a wide range of different diagnoses, a different diagnosis for every doctor they see, and try many different treatments that are focused really on managing the condition. And each doctor, though, it seems to be just focused on the back, just focused on where it hurts. And any of these minor abnormalities, which frankly, everybody in my older adult population has these minor abnormalities in their back, whether they have chronic pain or not. But when they have a finding, they say, that must be the cause. But it's obviously not, because the next doctor makes a different diagnosis, and none of these symptom focus that just target the problem in the back treatments are effective. So we really have to take a step back and look at how much the brain influences the body, and fundamentally how this collection of chronic symptoms that we're talking about, which can include pain symptoms and dizziness and emotional mental health symptoms altogether, how that fits together. And we usually find there are a series of causes that tie them all together when we go deep in psychotherapy.
Yeah. Yeah. And the parallel here, for those of you listening who don't have pain, although, Brandon, many people with dizziness also have pain, it's just secondary to their dizziness. So they're like, whatever, I'm not even thinking about that neck pain. I'm just worried about, having all this visual vertigo. We also have a whole subset of listeners, I see you guys out there, who don't have dizziness or related symptoms at all, and are here because they have pain or tinnitus, which is, I'm sure, something you see in your veterans, and hyperacusis, which is sensitivity to sound, and many other non-pain symptoms. But what they all have in common is that if doctors look hard enough, they will usually find some kind of abnormality, because our bodies tend to just they degenerate a bit as we get older. But most people don't have these symptoms, and certainly most people don't have these symptoms chronically. So that's one point. And then in addition, some of these folks actually do have an abnormality that does explain why they originally had symptoms. But again, most people with these kinds of abnormalities, for example, weakness in one ear, don't have persistent dizziness symptoms, or don't have persistent symptoms. So it doesn't explain the chronic symptoms, even if it explains the original symptoms. So again, same message here. What you're saying is very much the message that we talk about frequently on my channel. What made me think of, though, was that this, in our previous take, you mentioned something about how CBT, or cognitive behavioral therapy, takes a management-based approach most of the time. And I'd like to go into what differentiates what you're talking about from CBT. And I think we need to kind of define what those are first. So maybe you can explain what a management-based or cognitive behavioral type approach to these symptoms would look like versus what you're describing.
Absolutely. So, yes, with the coping or management-based approaches, often based on cognitive behavioral therapy principles, as you're saying, there is often, usually, I would say, an assumption that, yes, gosh, there's something wrong in the body. There's something structural that's there, whether it's been diagnosed or not. and then, so the best hope is to manage it, keep it under control. And so one thing they do is changing the way you think about your symptom, not worrying so much, or what they call catastrophizing about your symptom, and changing your behaviors around your symptom. So you can schedule out your activities, pace yourself so that you don't overdo it. You can do guided meditations and progressive muscle relaxation to relax yourself, which can lower your pain.
And these are useful. They're useful techniques.
Yeah.
Sure. Yeah.
Absolutely. But they're not really looking at whether the brain, the mind, I use these terms interchangeably, is it involved in causing the symptom or perpetuating the symptom. And so that's what we're doing.
I'm so glad you're saying this, because as you're saying this, I'm just remembering a conversation that I had very recently with someone who's suffering from tinnitus specifically. And she, you know who you are. When you watch this, you're going to be very excited. She knows who she is. When she learned about CBT for tinnitus, she was like, but they're telling me that my habituation, the word habituation, for people who don't know, people often interpret that to mean getting used to something. Like your brain just kind of gets used to it and then it doesn't bother you anymore. This idea of what habituation means, which is, again, the goal of CBT for tinnitus specifically, and can be the goal of certain treatments for dizziness as well. It's based on a management model. It's basically saying, nope, there's a problem in the ear. The brain needs to just learn to ignore that problem in the ear. Whereas what you're saying is the problem isn't in the ear. The problem is in the software of the brain. And if we can modify the software of the brain using the mind, which I'm excited for you to talk about more, then we don't have a symptom anymore, regardless of what's happened or what originally happened in the body. That the problem isn't the issue from the body. The problem is in how the mind, or the brain in this case, really, how the brain is interpreting signals from the body. Reminding everyone that, again, these techniques were developed before we understood neuroscience as well as we do now. Not to say we know everything there is to know. Of course, the field is still developing, of course. But what we know now is that our perceptions are brain opinions, that your brain is constantly predicting what sensory information means, and that's what gives us a sensory experience. So habituation, or getting used to something, is a low bar. We can do better than that. That's what the whole speech was to say that, Brandon. I just wonder if you have any thoughts on what I just said.
Oh, yes. Lots of thoughts. Actually,
please. I'd love to hear them.
Agree. So I would say that medicine and surgery, these fields are very good when you have an acute symptom. Like you have acute abdominal pain, you go in and they say, oh, you need your appendix out. They do the appendix and you're better. And so thank God we have, like you said, I acknowledge, appreciate CBT techniques. And so I'm so glad we have modern medicine. What often happens in chronic symptoms is that the body has healed itself, but the memory, the perception, as you're saying, of the former injury is maintained in neural circuits in the brain. And so it actually takes over. So I would definitely say everybody who has a symptom come up should get a medical evaluation. Make sure if you have back pain, it's not something serious like a fracture, like an infection, like a disease that can be addressed, should be addressed through medical or surgical interventions. But most likely when those serious conditions have ruled out, it is a result, it's a consequence of what you're talking about, then the brain changes, which that's the cause of the chronic symptom, right? That is the cause of it, not something wrong with the peripheral tissues, even if you get a diagnosis of, well, I do see this minor abnormality, I see this slip disc. So we are, again, in EAET and ISTDP trying to address the causes of the symptoms. And by doing that, we must go into the mind, the brain.
Okay. So how do these methods address the causes? And if you could also just frame for us what you see as the causes.
Absolutely. Yeah. So, I mean, in EAET, we take the stance that people's brains are shaped through their life experience and how they've responded to their life experience. So if someone has lived a life with a lot of trauma in childhood and adult trauma, there's been stress, sudden deaths, divorce, losing your career, all of these kinds of things, people naturally adapt to those. They develop what we call defense mechanisms, and that changes the brain as well. And so people can have their brains sensitized or, adapted, shifted to predispose them to developing chronic symptoms when they have an injury, when they have something that goes wrong acutely. And the brain is primed to take that and make it into a chronic symptom. And of course, this is no one's fault. They're not doing it on purpose, intentionally, but it's because of the way the brain is shaped throughout life. And so it's these emotional stressors, right, that take an injury that somebody has and turn it into a chronic symptom. So therefore, by going back and addressing, what was going on in your life when the pain started? What were the emotions involved? What was going on earlier in life, in childhood even? Sometimes we go for veterans in their military experiences that shape their brain, and the defenses that they use, which may or may not be helpful, may actually be contributing to the symptom, trying to loosen those defenses up and help them emotionally process these experiences in a very direct, open, and honest way in the therapy to try to get to a different point, a resolution, to change the brain again into a healthier way that's not perpetuating symptoms and suffering.
Got it. So tell me if you agree with how I just understood what you said. So if, based on what I was saying earlier, the problem is that the brain is misunderstanding the world and it's seeing things through the lens of threat, essentially. That's what is causing chronic symptoms. Then we can change the lens, essentially, by changing the mind. So we can make a brain become less sensitive to threat by changing how the mind processes old threats. Is that right?
That's exactly right. Yeah, I think that's very well put. And so, and what we're really doing in EAET or ISTDP is trying to address, why is the brain seeing things through a lens of threat. Why? How did that happen to this person, right? What happened in their life that led their brain to be shaped in this way rather than in a way that led to resilience to symptoms and being able to live a life free of chronic symptoms. And so we can, through EAET, by processing those traumas and those emotional stressors differently, shift them over into a resilient manner by actually changing the brain.
Okay. So I'm hearing this question. It's like I hear the audience listening and I know what questions are coming up. I didn't have any trauma. My life was fine. My parents loved me. Yeah, I was bullied a little bit in school. Like, why am I having chronic symptoms?
Yeah, so I mean, some people talk about capital T trauma versus lowercase t trauma, but what I understand more about it is that it's not what happens to you. It's what happens next. It's how your brain has adapted to the experiences that you've had in your life.
What did you learn from it, essentially?
What did you learn from it? And not even like overtly, like what did you tell the story, right? But what did your mind, in the unconscious mind, learn about adapting to a person who is standoffish, like maybe your mother was, and not your mother, Yoni, but somebody,
Yeah.
or somebody who was cold, somebody who didn't give you love and celebration when you made straight A's. These kinds of subtle experiences that people have can change their brains and predispose them. So we are often looking at examining subtle, what some people might see subtle experiences, not a capital T trauma from someone's life, but something which had a profound effect in shaping their brain and something that can be addressed. So the beliefs,
I was about to ask.
patterns of thinking, the patterns of interacting with people, of dealing with stress that is inevitable in life, the way people have adapted to what has happened in their life, even if they don't regard what's happened as trauma, can still set people up toward having chronic symptoms. And it can be changed, which is great once it's all brought out into the open.
So, for example, say we had two identical people who had to deal with the exact identical stressor. Like, say, two people who work as computer programmers and they have a big project due, right? And then one person grew up in a very just average home and nothing really of note happened. And then the other person just had maybe a hypercritical parent. Everything was fine. There wasn't a specific trauma. Nothing would show up on an adverse childhood experience questionnaire. But that person started to learn, for example, so from this experience, what did you learn? This person may learn, I need to be perfect. I need to be perfect, or I'm going to lose my connection to the people who are important to me, right? So this project comes up, who's going to respond with more stress? What you're saying is the person, obviously, who had the hypercritical parent, maybe it wasn't a trauma, but this person learned to respond to that kind of stress in a particular way that now makes their nervous system more likely to respond in that same sensitive way when they have maybe a physical injury that should have healed in a couple weeks.
Right, and it's so connected to what you were saying about the brain seeing threats. So maybe now this guy sees the boss who may provide some constructive feedback that everybody else would say, "Oh, thank you," and this person perceives it as a criticism and gets really emotionally upset or has a symptom, in the midst of this stressor, right?
Yeah.
So I think that's a great example, Nate, exactly what we're talking about that can happen without somebody experiencing like a major traumatic event.
Right. Gosh. And then as you're saying that, I'm thinking, then you throw in the fact that sometimes onset of these symptoms is scary for people, especially, I mean, guys, again, not calling out any specific group of you, but many of you who've had dizziness as your primary symptom, the onset was terrifying, even if it was a minor or temporary issue like benign paroxysmal positional vertigo or BPPV. It's already stressful to go through that kind of experience for anyone. And if your brain is kind of predisposed to see threat in a particular way, it may see the symptoms as threatening. It may also see the providers as threatening. A lot of people, unfortunately, encounter these providers who are not very empathetic and not very understanding, and maybe family members who don't understand. But what you're saying is that this affects not just people's relationship with symptoms, but also relationships with other people and themselves. And all of those things are cumulatively causing them a lot more stress that can lead to more threat prediction and more symptoms. Is that accurate?
That is exactly right. So what we're doing is called emotional awareness and expression therapy. So these stressors, like if you had a critical parent or you did have a major trauma, what are the emotions that you had about that? And were there emotional aspects that you neglected? So some people may not have ever cried when they had a family member suddenly die. And other people may have had that critical parent and never learned to assert themselves properly. So there can be different kinds of emotional experiences people are blocked off from. But what generates emotions in us? It's other people, right? That's the main thing that makes us feel stuff is other people. So a key component of EAET is focusing on the relationships that you've had in your life and how you deal with those relationships, whether they're causing stress and symptoms for you or whether it's a good, healthy relationships, and then working through in a very systematic way all of the complex and often mixed feelings you have in relationships and being okay with feeling that way and not having to go to threats and perception of threats and symptoms and defenses that are unhelpful.
And you're saying that doing that in this systematic way changes the brain.
Absolutely. Right.
Yeah. Okay.
Yeah.
Wow. So very different from the CBT type of approach, like again, especially ones that are based in management, but also it sounds like there's a really big difference in how it might look in practice in a session. So can you maybe give me an example of what a session would look like if we were to compare, someone getting kind of a CBT explanation or CBT type strategies versus someone who was working with you with EAET? What would that look like?
Sure. So I would say because we do have CBT in the study that I mentioned, and I've observed several, quite a few sessions there. And so they tend to come in, do a symptom check-in about how they're doing with their pain and so forth, which is similar to how we do it in EAET. And then usually there's a discussion in CBT about a thinking strategy or a behavioral strategy, and people are coping skill, and people practice that coping skill together. So they might actually do experientially progressive muscle relaxation or guided imagery, for example, during the session. And then they discuss homework, and it's often written homework or application of the skill they learn in the session. So again, it's learning skills, really skill-based. So in EAET, we do the symptom check-in, and we try to then, if the pain's up, if the pain's down, examine that from an emotional perspective. So if your pain's up this week from last week, what was going on in your life? Patients often say, oh, well, I was up on a ladder and I fell off, I twisted my back, I was doing too much yard work, I was overdoing it. But we say, well, what happened emotionally? And there was one stunning example where a patient came in suddenly in the middle of treatment and said, oh, I have 10 out of 10 pain today. So, oh my gosh, what happened? And he said, I have no idea. I have no idea. Well, in the course of the discussion with him, he he said, well, nothing happened except last night I was woken up at 2 a.m. with a phone call saying a family member had passed away, and I had to get up and go and deal with this. And it's like, do you think that there's any connection here that now you're coming in this morning with 10 out of 10 pain? So the first phase is really identifying those stress symptom connections. And then the second phase is once we hone in on an example, like a patient getting that phone call, then say, can we look at how you feel right in that stressful emotion? Because most of the time the patients are like, oh, well, I didn't have time for my feelings. I had to act. I had to do that. Like in this example I'm giving, this real example. And so we say, well, can we take the time now to process how you really are feeling about what happened last night in a very systematic way? And that's usually checking in about, is there anger? Anger can be a healthy emotion. Sometimes it's a natural emotion in many cases in any event. So giving space in the session for the patient to feel their anger, talk through their anger. So they're actually not taking their anger back into their life. They're doing it within themselves in the safe space of the therapy. And then is there any guilt? Is there any grief or sadness? And then hopefully ending on self-compassion. Once people get in touch with sadness, with the vulnerable feelings, especially about something that's happened to them, they can feel sad for themselves in a really open and honest way, then that usually leads to more self-compassion. So the outcome of the session is self-compassion, reduction in the symptoms, but we often have to go through a lot of difficult feelings and in order to get to self-compassion by the end. And honestly, we frequently have patients, their pain level drops often precipitously, sometimes even to zero, as they work through a stressful life event. And in later sessions, it may not be something that's immediate that's happened, but we process things that have happened in their past, traumas from the past, or relationships, examining relationships from the past in later sessions.
Well, I'm glad you said what you just said, because I was thinking one tricky thing that people tell me, there are actually two tricky things. There's the anxiety and OCD aspect of this that, people will get fixated. Oh my gosh, what was the stressor that made my symptoms worse? Oh my gosh. And then they get like hyper anxious about trying to find the one thing. And I'm constantly telling them, okay, don't worry about what the one thing is. Let's focus on responding to symptoms differently first. And then we can look back honestly. And because when you're that intensely worried about it, it's not helping you at all. So there's that. But then also with a lot of people, especially with dizziness, the symptoms are 24/7. And the only triggers people can seem to identify at first that make symptoms worse is physical triggers. So they'll notice, oh yeah, there's no relationship at all with my emotions at all, Yoni. They are at a 10 out of 10 all the time. The only time it gets a little better is when I sit down. Or they'll say, I'm at a 7 out of 10 most of the time, and then I go to a 10 out of 10 anytime I go for a walk. And there's just there's no change. So it sounds like what you're saying is, for folks like that, it doesn't mean that they're not dealing with the same issue that you're describing with chronic pain. It's that sometimes your brain's predicting threat all the time. And in those cases, it sounds like what would be useful, and you tell me if this would be a strategy you would use. It would be useful to first look what was going on in my life at the time when the symptoms started. That might be a good place to look. And then also looking at current relationships, and especially if they have parallels to past relationships that might have been, shall we say, trickier. So I'm always asking people, stop worrying about a specific moment in time. If you follow this pattern that I'm describing, stop worrying about a specific moment in time when something triggered you. Ask yourself in general, what's my relationship with myself like? What's my relationship with other people like right now? Let's start with that. Does that sound like a reasonable modification for people like I described?
Yeah, that's absolutely consistent with what I would do. I mean, I was thinking along exactly the same lines, we have patients like this who very difficult for them to appreciate at first, pain going up and down in relation to stress. And so usually though, with any patient in the first session, I ask, what in the heck was going on in your life when this started? Because honing in on that experience, and they say, oh, so I had another patient that had gotten into a car accident and in 1984. I work with older adults, as though this is when it all started. And so you say, okay, car accident, he had an injury, and then chronic pain ever since. But what was going on in your life? And he said, well, after the injury that I had, I couldn't do my job anymore, which was moving boxes in a warehouse. So I lost my job. And then my wife, who thought I was the sole support I was the sole support for the household, she divorced me because I wasn't able to support her anymore. And so this man lost everything as a consequence of this car accident that he had gotten into. And so it's like, my gosh, did you ever have the space, take the time to process your feelings about that? And no, it really never occurred to him, right, that he needed to process his feelings, and that the perpetuation of this pain for 40 years may have had something to do with the emotional aspect of what happened in the aftermath of the accident, rather than the physical effects of the accident itself. And so, definitely, it's about helping gently, not in an anxiety-provoking way, as you said, gently shift your attention over to pay attention to your emotional life, to your emotions and your relationships. Put the focus there, put the attention there, because that's what we can help with, right? If the medical doctors, the surgeons, they haven't come up with anything for you, why are we still going down the physical route? It's not been helpful. So let's see if we can shift our attention over to the emotions and to the relationships, because that's where we can really make a change, right?
Right. And we're going to change the brain by doing
along the lines that I speak to patients who have those chronic symptoms that never seem to waver and are only affected by physical things on first glance.
Right. Wonderful. Thank you for validating that. I guess that's going to speak to a lot of people watching this. They're like, see those patterns. For the record, people get better at noticing them later, and they're like instant. They're like, you're not going to believe this, Yoni. I had an argument with my husband, and like while we were having the argument, I noticed my symptoms going up. But that is not typical at first. It takes time for you to start noticing those kinds of patterns. So don't be discouraged if you don't.
Absolutely.
So one small question, and then I'd love to hear more about the data, more about the study that you just published. When you say processing feelings, people want to know what that means. What does it mean to process a feeling? What does that look like in practice?
Absolutely. So in ISTDP, it's very simple. If you're in touch with your feelings or not, it's not a woo-woo or vague concept. It's very simple. So the first thing is you can name the symptom. So for instance, I am angry.
Oh, name the emotion. Yes.
I named the emotion. I'm sorry.
Yes. Yes.
Yeah, I am angry at you, Yoni. So you could articulate that. The second thing, which is the whole ball game, if you ask me, is the feeling part of it. Where do you experience this in your body? Where do you feel the feeling? That's why they're called feelings. It's not just something in your head, right? Going back to the beginning of our conversation about the connections between the mind and the body. So in ISTDP, the observation has been each healthy feeling, normal, natural feeling that we're all born with, has prototypical physical sensations. So with anger, if we continue with that as the example, feels heat, energy, power. You want to make fists. You are grounded, strong, right? This is the kind of physical experience we're going for. And then the third thing is called the impulse. This is the emotion part, because that's why we have feelings, like evolutionarily why feelings came about is because they are a signal to you to do something. So when you're angry, there may be impulses or emotion part to lash out at people, honestly. So the important thing is the third part, this impulse, as we call it, it's not what action you will actually take. Okay, very important to understand. This is what the feeling makes you want to do in your mind. And so it's very important when we're working on a difficult feeling like anger or like guilt or grief or hard feelings, to be very honest with yourself about what the feeling makes you want to do. And then when you get in touch with those three components, in touch with the feeling, then at that point, you can make an informed decision about what's important to you, what you're actually going to do in reality. All right, so if you're angry, I may want to lash out, but after I feel that, I let it pass, right? I don't try to block it. I just let it happen inside of me. Then I may decide to do nothing at all. I may say, I'm not going to act on this anger. Or you may assert yourself, speak to the other person, etc., in a constructive way. So we do that with each feeling, with each example, right? Try to get them to feel it fully. And then we have a discussion about, well, how do you want to act now that we got your feelings sorted out? How do you want to act in reality?
Thank you. That's very helpful. As you're speaking, now I want to get into CBT versus EAET and the study that you did. But before we do that, I'm just struck by this description. And I was just thinking how little this can happen in talk therapy. And no shade on talk therapy. Talk therapy can be really helpful. And there are wonderful therapists out there who talk with their clients. But this is different. This sounds experiential. This sounds like there's a lot of feeling and being in the moment with something happening in the body and in the mind. That's very different from talking about things, like analyzing things. Often, Brandon, you probably experience this as well. I work with people who know they know what went wrong. They know it. They've analyzed it to death. They can tell me everything in like a bullet point list, exactly what happened. But feeling it the way you described is very different from knowing it in in an analytical way.
So important. Yes, that is so important. So, an analogy that I said to a patient a couple weeks ago is like, we're not talking about jumping off a cliff. We are jumping off a cliff, right? And it is what it feels like for people. Like, emotions can be scary, especially these difficult emotions like anger that we're talking about here. But it's like actually doing it. So there's only so much you can talk about how angry you are at your mother or whatever without feeling it, right? Without doing it, without jumping off the cliff, right? And that's what we do in EAET. And that's the part that I think is so transformative. So there is this old psychoanalytic term from Alexander in French called corrective emotional experience. That's what we're trying to facilitate, that experience in our EAET sessions. And that's what we think really helps people. It's like a total reset. Like, it's a powerful moment of where I don't need to be concerned about my boss criticizing me anymore. My boss is trying to help me. Like, now that I have my feelings sorted out, it's amazing how patients see things they never saw before, but you have to have that experiential component. And
Yes.
so as a therapist in this orientation, I'm paying attention to the patients, what they look like. They're nonverbal. Like if you are talking about being sad, you may look like this right now. But no, we're trying to cry, right? And so we watch that. And with anger, like I said, that physical, visceral experience of it, not just talking in a very even tone about being angry. So it's the experience which we think is so critical, as you said.
And research backs this up. So for those of you who want to know more about why this is so important, I did an amazing interview with Dr. Tori Olds on memory reconsolidation research.
Uh-huh.
That explains what you're talking about, why it's transformative. It's not just what we call counteractive, which is what CBT methods often teach you, which is to, act differently or think differently when you have the impulse to act in the old way. You have a new strategy that you use to act in the new way.
Right.
And that's great. There's lots of room for that in recovering from chronic dizziness and pain and tinnitus and hyperacusis and other symptoms. But if you want effortless change, like what you're describing is, it's not like the person seeing the critical boss and going, okay, wait, no, I'm supposed to remind myself I need to be self-compassionate. The person truly sees the boss as non-threatening. It's just gone. The old impulse is just gone.
Right.
Right.
And like I said, I mean, it may sound like voodoo to some people, like, oh, how is that possible? But I mean, it really is when you have a different experience, like I said, and it's a very systematic fashion that we explore emotions to facilitate this. I think it's very reliable that it works if patients are willing to engage in it.
So that segs perfectly into how well does it work? So you just published a study on this, comparing cognitive behavioral therapy, management type approaches to EAET. So do you want to just briefly describe what you did and what you found?
Yes. So, yeah, you're speaking about our paper that was published in JAMA Network Open on June 13th, and it compared emotional awareness expression therapy and cognitive behavioral therapy in older U.S. military veterans who had chronic musculoskeletal pain. So we had 126 veterans over the age of 60 with either back pain, neck pain, fibromyalgia, tension headaches.
Migraines?
We did not include migraines. We included tension headaches because we were just focused on musculoskeletal. Like most people think migraine is a different pathway. So I know I have some colleagues that are trying to study migraine. But
I'm very excited to hear that because what I think there's a lot of overlap between that and what we're seeing with chronic dizziness. But from my perspective, preliminarily, and you may disagree with me, I think it's the same thing. I think it's still a central sensitization issue, a neural circuit issue that's going to be helped by EAET and similar approaches. So just saying my words there, but you don't have to speak to that specifically. I know the study wasn't about that.
Right. Yeah, I would just say that's why I said some people regard migraine as having a different. So I don't necessarily disagree with you there. But so in our study, most of the patients, like 96%, had back pain. Okay, and so we had other diagnoses, but it was very common for people to have multiple pain diagnoses. So there were 126 veterans that we randomized to EAET or CBT, and we delivered both as groups primarily. So they got one individual preparatory session, and then they went into a group, which was a 90-minute session once a week for 8 weeks. And so
it's not long.
It's not long. No, I mean, we're talking 2 months, right? Or 10 weeks, including the run-in period with the individual sessions. So before we and after the treatment and at 6-month follow-up, we evaluated pain intensity. That was our primary outcome, and also pain interference with mood and activities. We evaluated depressive symptoms, anxiety symptoms, PTSD symptoms, because in a veteran population, we had about 37% of the sample had a diagnosis of PTSD, and global improvement and satisfaction. And so uh, nearly every one of those outcomes, EAET outperformed CBT at the end of treatment, immediately post-treatment. And at 6-month follow-up, so we're talking 6 months after the end of treatment, the EAET group still had within that group a significant improvement in all of the symptoms that we measured.
Wow.
And there was still advantages in EAT over CBT for the severity of people's pain, depression, and their global reaction to how much better do you think you are. There was more, people thought they were better, more better in the EAT group than in CBT all the way out to 6-month follow-up. So very interesting and has
very interesting
attention.
Yes. Yeah. So you may not be allowed to do this because you're the researcher and you have to use words like, well, this is what we studied and these are the outcomes and it's exciting and we'll see what happens. But I can say this, if we extrapolate from this, then this has huge implications for people with chronic dizziness, chronic pain, these other chronic symptoms, who, again, if they're lucky, they're getting CBT right now. If they're lucky, they're getting recommended CBT. But it has huge implications that we can do better, and that better can mean a psychotherapy intervention. It can mean a relatively short psychotherapy intervention. We're talking 8 group sessions. This isn't even like, here, let's spend 3 years digging into, everything you ever thought about your parents. This is quick. This is quick. And that has, again, as far as I'm concerned, enormous implications. Although it doesn't surprise me, given everything we kind of led up to this in the rest of the interview. I think people by this point understand why we would maybe expect this to be the outcome of the study, but it is so exciting to see it in black and white and in a major medical journal. So that's just congratulations on that.
Thank you. Yes, we're quite proud and excited. And so like I mentioned, we have another study that is repeating this comparison. We're doing group EAT, CBT, and also mindfulness meditation, because excellent. I think there's like some really interesting overlap in some of the mechanisms between that and EAET. So that has 3 arms, and all the groups on older veterans are delivered virtually. So that's the new study we're working on, and it's a 2-site study. So we're also involving patients from VA Connecticut, as well as where I am recruiting from VA Greater Los Angeles.
That's awesome. Wow. Well, I know your interest is in veterans, but do you have any opinions or thoughts on how these findings might generalize to people who don't have the kind of post-traumatic stress that veterans might have? Do you think that we might even see, again, I'm leading you here, but of course, please feel free to not take my bait. Do you think that perhaps we might even see a greater effect on people who have less trauma or less, less emotionally difficult stuff or less stress that they have to process or work through before getting better?
Sure. So yes, you are asking me to get into speculation as
it is speculation.
I've got my clinician hat and my research hat that I can use to speculate.
Okay, please.
But in trying to unite those, the biggest thing I would say is we found in an unpublished analysis of all the patients that have ever been in the pilot study I mentioned or in this study, there was a correlation between the level of attendance, how many out of the 8 sessions did the patient attend, and their outcomes, the amount of pain reduction that they got for EAET, but not for CBT, which was really fascinating to me. But so that is completely consistent with my EAET clinical experience, which is EAET is really, I want to say this, it's not a miracle cure. It's not a magic bullet like you might see on a late night infomercial. What we're saying is that we don't have the answer. You, the patient, you have the answer. It's inside you. It's been inside you all along. I can help you to bring it out, right? Which is through processing these emotional experiences that we've discussed. So the greater engagement that the patient has, the more they put in, the more they get out of it, right? And so, as I mentioned earlier, a lot of the treatment in this study involved just getting the veterans on board to the point where they would pick a stressful event or relationship and do the emotional processing. There's a lot of debate, discussion. For instance, we had a veteran that said, literally, I don't know if he's exaggerating. I'm really not sure in the healthcare system that I'm in, that he saw 12 doctors that are different specialties working on his pain. And
Oh yeah, it's not unusual for my folks to see upwards of 20. So
20,
not surprised. Yeah.
And they all 12 said that you are stuck with chronic pain. It is not going to get any better. You need to learn to deal with it, cope with it, manage it. And so there was extensive discussion about, well, how are you saying something different? How are you saying that, oh, well, maybe it is changeable? We don't know. Maybe we can find out if we try emotional processing work. So I think if somebody in the community could be more on board and could hit the ground running and do the emotional processing work from the first moment, and I think they could get even bigger benefits than what we're seeing in the study, regardless of how much trauma they may or may not have experienced in their lives.
Yes. Very, very hopeful note and consistent with what I've seen. I mean, again, my people come to me with, again, just having been told over and over and over again, there's no hope for them. We don't know what's wrong with you, or we know what's wrong with you and it's chronic and just manage it forever and ever. But we don't even have good management strategies for you either. So it's really, really a mess. And they get better with this kind of work. They get better. So, just wonderful to have you here. What a delight to be able to talk to you about this, which makes me wonder if you have any suggestions for people who say, okay, I'm sold. I want to try emotional awareness and expression. How do I find someone to help me with it? And if I can't find someone to help me with it, or I can't afford to have someone help me with it, can I get started on my own? Is there anything I can do to try to use this?
Yeah, so I wish I had a very straightforward answer to that question. And I wish there was a website with all the therapists that could do this on it. Mm-hmm. Unfortunately, that's not where we are right now. It's still new enough. So ISTDP, there is a list more or less. I'm involved in a nonprofit professional organization called the International Experience. Gosh, these acronyms I know, but
yes,
IEDTA. So their website, iedta.net, has a list of therapists that do ISTDP. So that is I can't endorse any of those therapists. I would say give them a try if there's one in your area. That's something you can look at. There is a training that Mark Lumley and Howard Schubiner provide for EAET that's for therapists. And so
I'm trained in it.
Yeah.
Yep.
More therapists are getting trained. And so you may be seeing on different therapist websites that popping up that they've completed some training in EAET. So I hope that that's more and more the case, because I've heard there's a wait list of hundreds of therapists to complete this training, especially since this paper came out. But Howard Schubiner's website is also has some listings sometimes of trainings, educational programs for patients that are along these lines.
My free course has a lot of EAET elements in it, and it's free also.
And your free course as well, I think is a fantastic resource. We have, talked about that before. And Howard Schubiner has a book that is like a workbook that somebody can do on their own called Unlearn Your Pain. I don't have a financial stake in any of these things, but
neither do. Yep.
Everything I can think of. But yeah, he has a book available, workbook, and there are other books like by Alan Gordon. I mean, Patricia Coughlin, I mentioned, there are books on ISTDP. You can read about this kind of model to try to take. I also recommend the work by John Sarno if you have,
for sure,
if you have back pain specifically, but any of these kinds of symptoms, reading Dr. Sarno's book and just learning about it has been helpful for some people. But so I think it's difficult to just go out and find yourself a therapist who can do EAET at this point, but hopefully it'll get more and more out there.
Yes, agreed. And one additional resource, if you agree with me on this one, the PPD Association, not all of the practitioners, but ppdassociation.org. I'll put all these links, by the way, everyone, in the description, so you don't have to remember any of these links. But they have a listing of therapists and clinicians who are familiar with mind-body disorders, and many of us have. I'm on that listing too. Many of us have done EAET training or ISTDP training. So there's many of them will have that kind of training.
Yeah, thank you so much. I can't believe I forgot them because I'm speaking at their meeting next month.
Oh, wonderful.
Yes, but that's
all covered.
Fantastic resource. Yes.
Yeah. Yeah. Okay. Well, this has been such a useful conversation. Really, again, I most importantly, this just kind of brings together everything that we talk about in my channel and podcast, and shows that there's actual research going on that supports us using techniques like this. This isn't just, okay, I want you to go feel your emotions because I'm trying to be sadistic. There's actually good reason for us to think that this actually might help. And I look forward to the day when we have vestibular disorder specific research, which we don't have yet as of right now, 2024, but that's something I'm working on. So we will get that one day. I was wondering if you had any message you wanted to give, any words of encouragement you wanted to give to people who are dealing with these kinds of symptoms right now.
Yes, I would say that it's unbelievable how there is so little hope out there for these symptoms in the medical community oftentimes, but there is absolutely hope. I mean, many people can improve dramatically. Some people can completely have their symptoms resolved through the techniques that we're learning. There were, I had from 12 to 20% of my, keep in mind, older, average age 72, 73 years old veterans, still 12 to 20% in my studies, complete resolution of their chronic pain by the end of only 8 weeks.
8 weeks.
Yeah.
Wild.
You absolutely get out what you put in. You can, even if you can't afford or access a therapist right away, there are workbooks like we mentioned, other resources like your training, that people can do this themselves. And the answer is really like, you have to do it yourself. We cannot do it. We're not doing anything to you or for you. So there is an infinite amount of hope that is out there for these conditions, if we can get the message out like you're doing so well, Yoni. And thank you very much for doing that.
Oh, that's an absolute pleasure. Just an absolute pleasure. What a fulfilling and quite frankly, addictive line of work we're in when we get to see people get better like this. Right. When someone's gone through 12 or 20 doctors and has been told there's just nothing that can be done, and that person sends you photos like, I just went on a boat ride or I just went on a roller coaster. Like, just, you can't. I just can't.
I know.
It's so
Every
wonderful.
time we have a good session, at the end of it, I'm like, okay, this is the reason.
This is the reason.
I'm doing it. This,
Yeah.
this is why I'm doing it. We have all this regulatory stuff we do with the research. It's like, but this is the reason we're doing it. Is
Yes.
to help our patients get better.
Exactly.
Yeah.
Yep. On my end, it's like stupid administrative things and just, I'm not even getting, public exposure comes with some unpleasant stuff sometimes, but it just,
Sure.
it reminds me when I see someone get better. It's just like, okay, it's all worth it. It's all worth it. It's always worth it. Yeah. Okay. Well, so if people want to follow you and your work, you have a YouTube channel as well.
Well, I have a very teeny tiny YouTube channel at Brandon Yarns MD. If people want to check it out, there, it's really short videos on one particular issue related to what we've been talking about: emotions, the brain,
Right.
stress, trauma. So if you do want to check that out, I would.
I'll link to it too. And remember, my channel started out teeny tiny also. So, who knows where you're going to be in just a few years? It may be, it may be the hub for EAET related stuff on the internet. So thank you again so much for being here. This was such a lovely conversation. And yeah, everyone, thank you all for tuning in. And of course, if you have questions or comments, we'd love to hear from you. So if you're on YouTube, just drop them below. If you are not listening on YouTube, I would love it if you could head over to YouTube to join the conversation. It's honestly probably the best part of these podcasts is we also get to hear from you and interact with you. Also, if you could like, share, subscribe to my channel if you're on YouTube, give the podcast a follow. If you enjoy the podcast, please give me a 5-star rating. All of these things help us reach more people and get this information to people who need it. So again, thank you, Brandon. Thank you, all of you. And we will talk to you soon. Take care, everyone.
Thank you.
Bye.
Bye.